Assalamu wa rahmatullahi wa barakatuh. Bismillahir Rahmanir Rahim. We begin in the name of Allah, the most compassionate and the most merciful, seeking His guidance and blessings. As medical students, we believe that every step we take in the pursuit of knowledge is an act of worship when done with sincerity and the right intention. I, Atika Zainab, on behalf of IMSA, warmly welcome each one of you to CASEXCEL, Clinical Mastery Series Part 1. It is an honor to be your host for today's session. This session is all about strengthening our clinical practice skills. We will be learning history taking in internal medicine and the examination of major organ systems, followed by history taking in obstetrics and gynecology cases and examination of antenatal cases. These are the core skills every medical student must master early on as they form the foundation for diagnosis, patient care, and successful practice. In today's medical curriculum, we often get caught up in theory, but true mastery lies in applying that knowledge at the bedside. A well-taken history and a thorough examination can reveal a lot and help immensely in diagnosis. That is why this series is designed to bridge the gap between classroom learning and real clinical practice, helping us transition from students to competent future physicians, inshallah. To begin on a blessed note, I would like to invite Muhammad Abrarul Haq from GMC Asifabad, batch of 2024, to recite a few verses from the Holy Quran.
السلام عليكم ورحمة الله وبركاته. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. ألم نشرح لك صدرك ووضعنا عنك وزرك الذي أنقض ظهرك ورفعنا لك ذكرك فإن مع العسر يسرا إن مع العسر يسرا فإذا فرغت فانصب وإلى ربك فارغب صدق الله العظيم.
Allahumma barik, Jazakallah khair for that beautiful recitation. Before we dive into the session, let me talk about IMSA briefly. IMSA is a non-profit initiative taken by Medicos from all over Telangana with an aim to create a unified platform for medical students working towards self-improvement and upliftment of society under the divine guidance of Islam. Our vision is to empower medical students to become compassionate professionals with strong spiritual grounding and social responsibility. Now, it's my honor to welcome our first speaker, Dr. Ahrar Ahmed Feroz, MBBS MD in Internal Medicine. Sir will be enlightening us on the fundamental aspects of clinical practice, history taking in internal medicine, and examination. Sir, we are truly grateful to have you with us. Over to you, sir.
Assalāmu wa Rahmatullāhi wa Barakātuhu. A very good evening, one and all. Hope I am audible.
Yes, sir, you're audible.
Yeah, thank you. So I am Dr. Ahrar Ahmed Feroz. I've been practicing at my own hospital, Ahrar Multi-Speciality Hospital at Tolichoki. So it's been a very interesting to see so many people, almost 100. That's excellent. And to my understanding, you people are from first year to final year, right?
Yes, sir, there are also interns in the meeting.
They are also interns in the meeting. That's great, mashallah. So it's very difficult for me to cover this in a very short span because the topic is very mass. Okay, so let me try to figure it out how much I can be able to complete it, and let us see to best of my abilities how much I can do it for you all. Okay, so I never expected that clinical teaching or bedside teaching care could have been online as well. So it is a very, very difficult part to me to conduct an online class for a bedside teaching. But I'll try my level best. and try to make sure that I try to help you all and try to make you understand and utilize this quality of time we are trying to put in. So that way. Now, there was an era. What is history taking? So this is the first part as a clinician which we have to really understand. See, what exactly happens is history taking is definitely an art. You have to learn it over a period of time by interacting with lot of patients of yours. So it is very, very important. There is to be a communication part. And one very important thing is this art can be learned very easily. It is only by practice it will make you perfect, and that is the only. There is no substitute. There is no shortcuts, and there's nothing like what Dr. Ahrar is teaching us today, or what I have been learned by reading Hutchison manual or reading any other clinical textbook will give you all. So this is very, very important. What is important is trying to just communicate, making sure that you are spending time with the patient to develop the skill. And is it one thing which always happens is like as a clinician, as a student, sometimes somebody will be shy, sometimes there will be a language barrier, there will be a lot of issues when come because we will be seeing different population of people, different sect of people, different languages. There are so many things. In that way, there's always understanding okay, how will be able to see so many patients. I don't know Telugu. Probably I live in Hyderabad. I was very, very difficult in Telugu. But if you see over a period of time, you learn it. But the native language is very, very important. So you people as a students have to understand that you have to be well versed with a good amount of reasonable English. Urdu is our mother tongue and we will be knowing that. And very, very important is you have to, when you're here in Hyderabad and when you are, or any part of Andhra Pradesh or Telangana, you have to know that you should be knowing some amount of quality good language. Telugu language is compulsory. That is an advice where so the people who are in your first year and second year medicine just start concentrating on learning some basic Telugu. That will help you all in being better doctors as well. Okay. So now today, as the topic given to me, like history taking in general medicine and an overall, so we will try to initiate it and let us see how much we can complete it in this part of the section. So first and foremost, as I told you, once that communication is there, after the communication, the important part is how do you receive the patient? How do you portray yourself? These are very, very essential part. See, now it is mostly the students which are interns will understand and those students who are in final year will understand. We are into a phase of evidence-based medicine. So what is evidence-based medicine? Now everything has to be documented and proved individually. That is why we see for everything the imaging has increased. We have to have a tissue diagnosis for everything. We have to do a biopsy or we have to do something or the other. That is known as evidence-based medicine. That means whatever is documented. For example, when I was a student, all my professors used to insist 100% on a clinical examination, a good history taking. So whenever our turn of presentation as a doctor was there, as a student, whenever we were advised to present a history taking, that would have been a very difficult day for us because history taking and giving to a professor was so difficult. But now, because we think history taking cannot be there, we can jump directly to the investigations. Most of the time, the students I see who are coming out, who have been recent past, as soon as the patient with chest pain comes, yes, ECG is a very important thing. But first and foremost, before going to an ECG, spend some quality time with the patient and make sure that you come to a clinical diagnosis without using that. This tool is very, very important. And still in India, and I think another couple of years more, few more generations, I think history taking will still exist, and that is the essence that is why I'm trying to concentrate more on you people to understand that history taking is very, very essential and essence part of being a clinician in every aspect. Either you are, if you want to be a surgeon, if you want to be an ophthalmologist, if you want to be an orthopedic surgeon, if you take a quality history, the patient will tell you a diagnosis if you hear it in a proper way. So now coming back to our thing, okay, how are we going to start? So first and foremost, the what important thing it is there in history taking is comes as the personal data. I don't know whether this is clear or no, but I'm trying to just do it because see again, I didn't want to use the PPT slides or things like that to explain it. I just wanted to make this more practical for you people to understand. Okay. So in history, personal data, first and foremost, whenever the thing comes, what you have to see is the personal data. What is the personal data which comes? Personal data is nothing but name, first and foremost. Then comes age, the sex, their occupation, and last but not the least, their religion. So why are we concentrating on name? Name will see. As soon as once a patient walks into your consultation chamber or to address somebody, it's always better to name it. See, whenever you are going out, if you call somebody by just saying, "Hey Babu, you come here," if that looks good, or "Muhammad, please come here." So that even if you don't know the name, if you call him Muhammad, if nobody is there, he tend to turn around. So these are the basic etiquettes which is there. So name, and the other very important thing what happens is clinically, see, whenever you see an ECG or whenever you see, for example, a blood report, for example, if you don't see the name of that and just see, it happened with me as a clinician as well. So when the patient was presenting his reports, there were about bunch of about 10 to 20 reports. And I was just going through the first report I have seen, the name, age, sex, and address, everything was there. And we continued. And we thought all that 20 pages over that particular patient. And in between, the sugar levels were very high for that particular patient. We have written the sugar medication for him. And the other day, the patient landed up in hypoglycemia in the emergency department. So why did that happen? Because that sugar report, the name was the same, but the age and the other details in particular were very, very different. So it is not only in history taking to communicate to a patient. Whenever you talk or speak to a patient and then you address that with a name, it is very, very essential. See, these are the small things, but our professors used to be very particular in explaining about the personal data. Second is age. As you know, why age is considered? Because there are different age, there are different things which are at different ages. For example, a patient with 16 years old presenting with chest pain and a patient with about 54 years of age presenting with chest pain, there will be two different things. I cannot expect first my differential diagnosis as myocardial infarction in a 16-year-old patient, and whereas a 54-year-old male patient or a female patient present to us. So depending on what ages will have what different diseases. So that is where age is very, very important in differentiating our differential diagnosis. Third thing comes is the sex. Obviously, there are some diseases which are female predominant and there are some certain diseases which are male predominant. For example, we see sex-linked diseases. The example is hemophilia. Hemophilia will be in male patients with X-linked disorders. So these are the things which will help in identifying the sex. Again, occupation and which other important occupation, religion and address, which I have been missing is the address. So this is there. Occupation, again, as you know, you will be reading in your that coal worker pneumoconiosis seen in coal workers. या फिर diseases which are seen with glass workers, CA bladders is seen with patients using dyes and things like that. So for that particular region, occupation is very, very important. Address is very important. Patient, where it is coming from. He is coming from an urban area or a rural area, to differentiate between what exactly and how exactly it is coming. Is the patient coming from a rural area? Certain diseases, like for example, uh, 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 there will be disorders which are confined to the rural areas and urban areas. If patient coming from urban areas, we think of more of metabolic syndromes, hypertension, diabetes, etc. Whereas some things which are coming from the urban fluorosis and things like that are and some towards the belts, such as iodine deficiency from the Mediterranean area where there is less of iodide salts and things like that. So these are very, very important. Now coming to religion, as we see why religion is very important. Why religion is very important? Because as we know, example, patient coming from a Muslim sect, what we see in general, there are diseases which are associated with ethanol or alcohol. We can say that very rarely here. A Sikh community coming where they don't smoke, so smoking related disorders will not be there with them. So this is how we try to interpret our personal data accordingly. Okay? Now from the personal data, the second it starts is the chief complaints, which is very, very important. So the second important thing is the chief complaints. So what exactly happens in chief complaint? It has to be in a chronological order. How it is presented to the patient. How it is presented for him. In this, very importantly, whenever you're taking history, for first 5 minutes, what you have to do is like ask the patient to speak. Don't try to interpret what is happening and things like that. So if the patient is continuously speaking on his own, it becomes very, very easy. He tries to tell, and see what exactly happens is, if you try to give some leading questions to the patient, then they will try to nod as yes or no. So that for that particular reason, make sure that you are spending about 5 to 10 minutes of quality time to the patient, so that they will try to understand and make sure that they will give us that summary. And whenever you people are trying to take a history, at the end of the history, what it has to be there is, if you are presenting to your professor, or when you are trying to interpret, your history should be in such a beautiful fashion that every event should be narrated in such a beautiful way. At the end of the day, when somebody is hearing, or if you're presenting to a professor, it at the end of the day, he should have a diagnosis on its own. If you listen properly to a patient, it will happen. If you take, so you have to inbuild your art that it comes in such a beautiful way. Okay. So chief complaints. So what are the chief complaints? The chief complaints has to be in, and history of present illness has to be in patient own words. You should not try to interpret or try to put something. For example, a patient presenting with chest pain. A patient is presenting with, most common symptom is chest pain. And say, for example, he is having this chest pain for the amount of 8 months. So you cannot write that the patient is having chest pain for the 8 months. You have to find out, you have to come, why have you come to me now? If you have this chest pain for the past 8 months, no. So then he will say, for the past 5 days or 8 days or 3 days or 1 day, this pain has really aggravated. It has gone down from a very low part to a very on the severity trend. So in that particular way, you have to take it. Okay, understood this part? So sometimes always students have this complication that sir, the patient presents to this chest pain is for the past 8 to 10 months. And how can we write? Do we write in chief presenting complaints that the chest pain was there for about 8 months? No, you should not. You should try because it was there with you for so long, and why have you come at present? Okay. Now, from the second complaint, for example, after chest pain, cough, then fever. So if this, what came first, what came next, and followed by that. So this has to be in that particular fashion. Okay. So after the chief complaints, what are the complaints patients present to us? The next important thing would be elaborating these things in the history of present illness. After the chief complaints, it comes the history of present illness. So what we have finished is basically the personal data. Second comes is the chief complaints, CC, and the third will be the history of present illness. So history of present illness, now you can use the word that patient was apparently asymptomatic 8 months back, and then gradually he develops chest pain on and off. Then the symptom has to be elaborated. Whatever the symptom is. For example, if you are taking pain as a symptom, if the pain is there, the first and foremost should be the onset. Then how long it is there, duration. After the onset, duration. Then severity. How bad is the severity? Then what are the aggravating factors? What are the relieving factors? Is there any associated factors? So these are the things which have to be documented and narrated in a proper systematic fashion. Just before going further, hope whatever I am trying to communicate and whatever I am trying to speak, is it clear for everybody? Okay, fair enough. So this is how we are going to agree. So now in this onset, duration, severity, aggravating and relieving factors and associated factors, we have to develop. For example, a 54-year-old male patient comes to my clinic and says that, Doctor Saab, सीने में दर्द हो रहा. So then I'll ask for how long he has been having. कब से हो रहा भाई? So then probably you will take. And the other thing is, like, whenever you're trying to take a history, the other very important part is try to see the behavior of the patient, how it is going, and what is very, very important. For example, a simple thing which will be a patient complaining and telling me, Doctor Saab, yahan darad ho raha, kabhi yahan darad ho raha, kabhi ye darad ho raha. And sometimes patient can tell me, presenting, Saab, 1 घंटे से बहुत दर्द हो रहा. I am feeling, and you see that there is sweating on him, and he looked quite diaphoretic, and he looked very anxious. So automatically, you will be in such a position when somebody tells, "Meku yahan darad ho raha," you can see that he is using his finger and trying to point it. So very unlikely a cardiac part. It has to be a musculoskeletal, or it has to be something, because this will not be like that. And he will be quite relaxed. That's up, and things like that. But somebody who's diaphoretic, who's anxious, and this is a Levine sign, which probably, if time permit, is a very clinical. So it holds the fist, it closes the fist, keeps on his chest, and says, I'm feeling, I'm able to breathe. Then slowly he'll try to tell something. So then you should be anxious. So no, this patient should go to the emergency room immediately. It is something different, or what it is. So this is very important. And then duration. What is the duration? How did it started, and things like that. Then the severity, obviously, how bad it is and what kind. Severity, along with severity, you can always see that there has to be the nature of the pain. What kind of pain? Is it pricking? It is stabbing, or it is compressing, or it is burning. So these are the different things which we have to learn here. Then the aggravating factors. That's up. दूर तक दर्द नहीं था मेरे को, बट जैसा डोर से मेरा नंबर पुकारे and आपके कैबिन में आया, मेरा दर्द बहुत बढ़ गया. So that was on exertion. The patient was walking and there was aggravation. Walking has aggravated that pain. But अब अल्लाह का शुक्र है, बैठ गया, आपसे बात कर रहा हूँ, थोड़ा रिलीफ हो गया, इत्मीनान हो गया, थोड़ा दर्द कम है मेरे को. That means rest has making that. See, sometimes we need not कहीं को बढ़ रहा, कैसा बढ़ रहा, it is not there. So these are certain practical points which on keeping repeatedly asking or repeatedly talking to the patient, you can understand and try to interpret this. Last but not the least, relieving factors here and any associated things. What are the associated things we have just seen? Sweating, diaphoresis, difficulty in breathing, shortness of breathing. So these are the simple things which is there. So this is how. So how do you try to interpret? No. After this, we will try to take it. Next symptoms as we take again. If you remember in our past history, the second thing was cough. Again, cough, onset, duration. Is it dry or productive cough? Is there any pain associated with cough? Again, any relieving factor? Again, any actions? Almost the same things would be there with the other complaint. Last but not the least, I told in an example that the patient was having fever. Fever type. If has he documented, has he taken the fever? Was it on recorded by a thermometer, or he was just saying that my forehead was warm, my arms were warm, or it is that is very important. And then intensity of fever. Is it a low grade fever? It is an intermittent fever, or it is high grade fever, which is again very, very important. Then is it what are the associated? Is it associated with the chills, rigors? So then again comes what are chills, what are rigors. So I am trying in this class to just review of all the things. I am not going into lot of detail. For example, what happens if somebody has fever? There can be factitious fever. That means he's just assuming it. He's trying to tell that a fever is there and he's showing you a thermometer bringing that it was 1 not showing 103. He could have dipped in hot tea also and then shown the thermometer. He didn't want it would have been only a 12-year-old child or a 16-year-old boy who didn't want to go to the exam. He could have just put it in some hot water and shown to the mother. So in this, what we see, with each degree rise in the temperature, the respiratory rate increases by 4 per minute, pulse rate increases by 10 beats per minute, and the oxygen requirement increases by 13%. So these are the very important associated factors we try to take it and try to interpret things. So these are the small few things which you will be repeatedly learning on your things. So, for example, how do we present like this? Now, how do you write history of present illness? You can tell that with keeping the 3 complaints in our consideration, such as pain, cough, and fever. Patient was apparently asymptomatic 4 days back. Then he developed vague, diffuse chest pain, which was associated with cough on the 3rd day of the illness. The cough was mostly dry, but on repeated coughing, there was a small amount of sputum which is coming out. Sputum was almost white in color, which was non-smelling, very small quantity. It was coming out with some greater difficulty. Later on, the day 5 of the patient developed fever which was high grade, intermittent. It was not a continuous fever, it was intermittent fever. Fever was relieving by putting some tepid sponging or taking some paracetamol or things like that. See, most of the patient in this era, when patient used to come, initial when I was taking history, when my professors used to take, patient directly used to come, but now patient takes some medications and things like that. So they maintain that patient is coming to the hospital after taking paracetamol, or they will start some antibiotic and things like that will give you rehna. So this is the history of present illness, how you present. After this, after history of present illness comes history of past illness. So now, depending on the age of the patient, we have to take what are the past history. Now, very important is we have to keep this as a context of the disease and keep it. We should not tell that patient had fracture, humerus in his past. That is there, you have to mention in the list. But very important is if we thinking fever, cough, one possibility is tuberculosis. So, or bronchial asthma or any respiratory illness in the past. So, what is very, very important in history passer? First, try to take a history which is correlating. Any previous part has the patient got into the present, has to do something with the history of present illness. So that has to be kept, and then the other non-significant history will be coming in the later part of the section. So first and foremost, what you have to write with this construct which you are taking, that is the patient is a known case of any bronchial asthma, or patient in the past has tuberculosis. So this is very, very important. Got it? Hope it is clear. Okay, first you have to take relevant past history, and then you have to mention other. After history of past illness, what is there? Two things can occur. In history of past illness, you can club surgical history, or a different aspect, you can give a different heading as surgical history and write any surgeries in the past. Okay. After this comes the treatment history. Is the patient presently taken any medications, or in the past has he patient taken any kind of is he on some chronic medication, such as these days diabetes and hypertension and is in such a high incidence, okay, almost irrespective of the age group, most of them are on any kind of pills. So why history taking is very important. Sometimes some drug history, long-term drugs is causing the chief complaints or not. It's very, very important sometimes. So it is important that sometimes what happens is a patient will be having, is it drug induced? Just to rule out that, okay? Is there any interaction? Or if we have to give some medication to the patient, for example, if we have to write a treatment, so we have to make sure that we should not write any drug which gets interacted with the present treatment. So that is why treatment history is also very, very important. After that, personal history. What is personal history? Personal history is again occupation, we know because we have taken it in the personal data itself. So here, what kind of diet is he on? How is his sleeping pattern? How is his regular bowel and bladder habits? Bowel and bladder habits. Is he addicted or habituated to anything? So these are very important, because again, diet, there are certain disorders which are seen in vegetarians and there are certain disorders which are seen in non-vegetarians. So it is very, very important to know the type of diet. Then we should know, as we know, now we are in such an era, okay, there are lots of people, because I practice at Torichoki area, there's a lot of youngsters come to me who have been working in the night shift for almost 7 to 8 years consecutively. And in these patients, what I am seeing a lot of sleep disturbances issues, insomnias. I am seeing lot of hyperacidity, bowel disorder, dyspeptic symptoms. I have been seeing them developing some metabolic disorders because of the erratic eating habits. So all these things. So sleep is also very important. Then again, other bowel and bladder disturbances. Is he regular opening up bowels regularly, or any bladder? Is there any disturbances with his urination issue? Last, coming It's habits and addictions. Obviously, for sure, smoking is the most common thing where we see what is comes is the uh, smoking pack years. That is number of smoking cigarettes he smokes in a day for how many years he has been smoking. So when for more than 40 packs years if somebody is there. For example, somebody is smoking 20 cigarettes in a day for almost 20 years. So that is known as 40 pack years. And anybody with more than is at the highest risk of developing bronchogenic carcinoma. So this is very, very important. These small things you should try to understand. Again, people who consume alcohol is very important because a certain amount of alcohol does not cause, but after a certain amount of alcohol, we see a lot of alcohol-related diseases, which is most common is hepatic cirrhosis. And now, as we are into an era where there are certain abusive drugs in the form of marijuana and things like that. The accessibility have improved. People are getting it, and so that way it is also very important. But these social things which you are going to take it is very essential because you have to have that confidence where the when you take a proper history, then only you will have a proper confidence in the patient. Then he will be able to that's up very confidential rakte, and then only he'll open up and try to make sure that he gives a proper history about its habits and addictions. So this is how after all this, after the personal history, you have to have a small summarization of everything and try to in your brain try to find out okay what kind of organ or what where is the pathology and what I am thinking. So after whenever you take it, it will give a very good presentation if you just summarize a brief history before getting into the general examination. After this is basically get into a habit of summarizing things so that you will know okay, which organs is. So by taking a good history, you will be able to now chest pain, fever, and cough. Mostly what it happens, it could be lung first issue, second could be cardiac, it could be GI also. So everything is possible with this. How? Lungs, it could be a pneumonia presenting with initially chest pain with different phases of pneumonia, that is consolidation phase, red hepatization, gray hepatization, and resolution phase. So there's a lot of phases. So in that case, if pneumonia is developing here, they can present with chest pain, then cough will be there, then fever could be there. Then it could be cardiac asthma as well. In cardiac asthma, patient presenting as chest pain, then they are developing shortness of breath, fever and infection. It could be a reflux disease. GERD can be presenting as that, and the cough could have been there. It can be presented with chest pain. Fever can be an incidental thing on and off. So that way, you will be knowing it okay, what system examination has to be there and what system has to be examined. So if you take a proper history, then you will be classifying your things in a better way. So after personal examination comes is general examination. So in general examination, what are we going to see? The patient is conscious, coherent, cooperative, he is communicating nicely, he is well oriented to his time, place, and person. He knows where is comfortable and things like that. After that, we try to see pallor. Before this, is the vitals of the patient is very important. Uh, Taking the blood pressure, temperature, weight, respiratory rate. We are going to take this pulse rate. So this is how again, if you take in each entity, if I get into each entity, then there is a class. If you ask me to take pulse, That is why I'm telling this is a class where I was so confused where to start, what to interpret, how much to. If you want, I can just take one single class for 1 hour minimum in pulse rate. Where to examine, what are the different pulses has to be taken, what are the different types of pulse, what is the normal pulse, what are the different conditions where pulse will go. Same thing, blood pressure. If you ask me to talk on blood pressure, we have to go in detail. So we are not, I'm just trying to give you a gist and the network of how to approach a patient today. Okay. So once we have taken the vital data in general examination, conscious, cooperative, coherent, then vital data, then we should start examining the patient. Of all this, one very important thing as a student I'll tell you is always communicate to the patient, and whatever you are trying to do to the patient, try to talk to a patient. Try to explain them what they are doing. Just don't grab their hand and try to take a pulse and see, oh my God, ठीक है. No. If you want to take a pulse, tell, अरे अहमद मियाँ, जरा तुम्हारी हाथ का नब्ज देखेंगे, जरा हाथ दीजिए. And try to make sure if he's sitting in an AC, if you are sitting in an AC, try to rub your hands. Make sure that it is comfortable. Try to take some sanitizer. If the patient is hygienic, coming from a socioeconomic good background, educated, and you have been meddling with so many files and seeing, and then all of a sudden touching him. So make sure that you try to take some sanitizer, clean your hands, ask his command, just be courteous to him. जरा आपका दीजिए, कुछ नहीं, आपका हाथ देख लो, अरे मेरा हाथ को पकड़ रहे डॉक्टर साहब, नहीं नहीं आपका पल्स देखना है मेरे को, यहाँ पे तकलीफ होती क्या, नहीं नहीं डॉक्टर साहब तकलीफ नहीं होती, थोड़ा ऐसा दबाऊंगा, अगर थोड़ा तकलीफ नहीं भी तो हमारे थोड़ा जोर से भी दबाना पड़ता, आपको जोर से दबाए तो कोई तकलीफ तो नहीं होती, बट ठीक है. So thoda, so when you communicate, he'll be very comfortable. Otherwise, if you just grab a hand and see somebody's pulse, what exactly happens is anxiously his heart rate goes high. So that way it becomes very cumbersome and troublesome to you. It's a sinus tachycardia. Why it is sinus tachycardia? Because you just suddenly grabbed his hand and try to see his pulse. And if you, the rate and rhythm is seen at the radial pulse. If you want to see the character of the pulse, you have to see for the carotid. Again, as I told you, if I just get into the details of pulse, it will be much more difficult. So after this, we have to see pallor in the eyes on the palpebral conjunctiva. We have to make, in the eyes, we have to divide it into the palpebral and the bulbar conjunctiva. So in that fashion, the palpebral conjunctiva would be for pallor, just looking into the pallor. Whenever you are seeing it, who are you going to compare it? How it is going to compare it? Okay. So for all this, what I have done is I have an individual. So I'll be just demonstrating few things and probably it will be easier for you to understand as well. Okay. So I have क्या बोलना चाहिए? I have my son probably, so I'll be introducing and he'll be volunteering to us in trying to examine him. Okay, so he's Nabil, so I'll be just trying to examine him and try to just see how exactly we are trying to examine him. Okay, coming to Nabil, Alāykum, how are you? Okay, so you have been introduced to the class. We are taking a session for there are almost about 100 people sitting us and trying to just try to follow. Okay, so just relax and we are trying to examine you. Okay, so I'll be doing a general examination. So I'll be seeing your eyes. I'll be examining. I'll be asking you to open your mouth and things like that. Okay, you will be videoed and you are on a camera and people may be saying, I hope you don't mind. Not at all. Perfect. Chal, theek hai, inshallah. So whenever so whenever we are trying to see for the pallor, make sure again so pallor, as I said, this is the palpebral conjunctiva which is seen, and this is the bulbar conjunctiva, which is very, very common. So now when I have to compare it, I have to make sure that I am seeing. Nabil, आँखें खोलिए. Very good. थोड़ा सा मैं आपकी आंख को नीचे कर रहा हूँ. And when I do this, I am trying to compare the palpable conjunctiva of. I have to see Nabil divided into two things, and I have to compare on the both the sides. It is not that I have some color in my vision and I am trying to assume that. No, it is not there. It has to be Nabil's color to be compared and make sure that it is there or not. Following that, then I ask him to look down. Then I am going to see for the bulbar conjunctiva. Okay. For why do you see palpable conjunctiva? We will be seeing for cyanosis. For pallor, whenever there is anemia, there will be the whitening of the wound. It will be the pink color goes to white, or then second bulbar conjunctiva for hyperbilirubinemia. Whenever the bilirubin level goes beyond 2, there would be one condition, there is yellowing of the eyes. The bulbar conjunctiva will become yellow. There is a condition which is known as carotinemia, where you will have yellow color skin and things like that when the carotene content, such as which is there in carrot, somebody has used it, bulk quantity or things like that, the skin will be yellow, but the bulbar conjunctiva will not be yellow. So that is there. Then looking for the eyebrows, hair distribution, looking at the ears. Okay, ears are there in the similar pattern or not. Low ears, which are known as hypotiroidism. Usually what exactly happens from the inner canthus, the ears would be very low. That is seen in Down syndrome. Then I ask, मुंह खोल के बताइए, मुंह खोलो पूरा, अच्छा मुंह खोलिए. Very good. I just do the oral dental hygiene, how it is. I just sit down and watch into the eye and make an imaginary line from the lower incisors to the uvula, making sure how is the palate. If it is high arch palate, which is seen in gigantism and acromegaly and things like that. So the palate is now not oral hygiene. I'll see the uvula, I'll see the tonsil, I'll see the tongue. What is the color of the tongue? Then again, tongue is is there a wasting or not? Is there any discoloration of the tongue? Their geographic tongue, high colored tongue, coating on the tongue seen in jaundice or in other systemic illness and things like that. Then after the pallor, icterus. Second the third is clubbing. Clubbing is usually what I do. I ask this, I take the finger, I'll make sure, and I just look into this vision and see the Louis Bond's angle, which is the angle between the nail bed and the nail and the nail bed. So just this angle is the Louis Bond angle, which helps us to identify and see. If this angle is more than 120 degrees, then it is known as clubbing, and clubbings are divided into 4 grades: grade 1, grade 2, grade 3, grade 4. Again, clubbing is a big topic. If I just get into clubbing, we have to talk more about clubbing. One is shamrock sign. I ask the patient to just keep the fingers, both the digits together, if you can see, and there would be a diamond form. This is known as shamrock sign. If there is this sign, diamond is not formed, then the Louis Bond angle is lost and it is known as clubbing. Okay? This is how you have to keep it. You have to both the samne ke both the nails put together karna with the last proximal joint ko join karna. Yes, very good. So this is how you will get that. After the clubbing, pallor, icterus, clubbing, lymphadenopathy. Then I have to examine the lymphadenopathy. What are the grades? Where are the lymph nodes? Valder link. We have seen the tonsils, axilla, groins. These are the places where you have to examine for lymphadenopathy. So first and foremost, very common, whenever we are seeing the most common lymphadenopathy, we go behind the patient. I go back, keep his neck flexed, use the pulp of my fingers and try to palpate all the lymph nodes, where under the mental, then under the maxilla, then in front of the sternocleidomastoid and behind the sternocleidomastoid, post-auricular, pre-auricular, occipital with a thumb. So this is how I will be examining for the lymph nodes, whether the lymph nodes are enlarged or not and things like that. So this is how I am going to examine for lymph nodes. After the lymph node, what comes is the pedal edema. I'll just try to see the fullness on the face. Is there generalized anasarca with fullness, limbs, fingers are thickened, or is there edema in the legs or not? Again, there are different things. What kind of edema it is? It is a pitting edema. What is pitting edema? On the shin, if I compress for about 30 seconds and remove my thumb, there is a dip seen on the skin. And this dip, if it stays beyond 1 minute, that is beyond 30 seconds, it is pitting type of edema. But if as soon as I remove my pressure, if the skin comes back to the normal and there is no indenting on the skin, which is less than 30 to 40 seconds, the skin comes back, it is non-pitting edema. So this is how we differentiate between the pitting and non-pitting edemas. So this is the basic general examination we have. So what have we done? We have taken the vitals, we have seen the neurological status, we have taken the vitals. Following vitals, we have seen pallor, icterus, clubbing, lymphadenopathy, pedal edema. So it is pneumonic. There's a pneumonic pickle which we used to read in the skin. I think that is still continuing. Pickle is the pneumonic which comes for that. After this, we get into systemic examination. Now, systemic examination is respiratory system, cardiovascular system, GI system, GI and GUT, gastrointestinal and gastrourinary tract system together, and CNS. So these are the 4 systems which we are going to examine. So whenever as a final year student you are given a long case, depending on your clinical history, you have to decide which will be your primary system examination, which you do it in detail, but on a long case, you will be doing other system examination also, but not on detail. Only the examination which you think according to the system, you will do it in detail. Other system, you will mention it. You have to write in your case sheet other system examinations as well. Okay. So, how does the systemic examination? Systemic examination is divided into very simple 4 parts: inspection, palpation, percussion, and auscultation. What do? On first and foremost, always stand on the right side of the patient whenever you are going to examine. That is the right. So whenever you ask or there for examination, please be on the right side of the patient for examination. That is the first and thumb basic rule of the patient. And then inspection is you need not touch the patient. You expose the area. For example, if you are examining chest for this, if we are examining chest for this, undress the patient, ask him, make to a favorable condition. Very importantly, make sure that the things are curtained out. Don't just try to open the shirt of a patient and all. Where I see most of the patient doing, students, and probably as a student, I might have done it. But we have to, and again, talk, be polite to the patient, be empathic to the patient. That is very, very important. Empathy has to be there. It has to imbibe in our blood as being doctors, as we have taken this profession. Like it or not like it, you have to be empathic to the patient. That is very, very important. So you have to examine on inspection. You are just from the right side of the patient, in sitting position, in lying down position. You are going to anteriorly and posteriorly. You are going to see and write all the inspectory findings. For example, you can write barrel-shaped chest seen, trachea appears central, nipples are in the straight line, there are no scars, there are no cyanosis, there are no pigmentations on the skin. So this is how you present it. This is how you present the inspection. Second thing, palpation. You have to confirm everything. Whatever you have inspected to the patient on palpation, you are going to confirm it. For example, there's a trail sign. How do you do a trail sign? By using our hands this way, whether the trachea is central or not. Nabil, I'm opening up your first button. So by fixing our 2 fingers, that is the ring and the index finger, on the sternocleidomascular joint, and taking the middle finger and rolling down the trachea and insanguinating our finger in in between the trachea and the sternocleidomastoid on the both sides. If my finger is insanguinate both equally on both sides, this is known as the trachea central, and my inspectory finding of trachea central confirmed by trail sign on my palpation. Same way, I'll be palpating the apex of the patient by using my ulnar border and making sure which sternocleidomastoid, which intercostal space the pulse is coming, and I'll just try to localize it, come to a point and make sure that it is happening and trying to get it. Okay. So this is very, very important. Last but not the least, confirming all my palpatory. Then percussive finding. By percussing, how are we? There's a fleximeter and flexivo. So by fixing my middle finger using both the middle fingers of our hand. So one hand fixing on the intercostal space and second tapping it up. So this is how we'll be doing our palpatory thing. And now coming last but not the least to the auscultation. We are trying to auscultate the different areas and trying to confirm what it is. Now again, how are we going to do it? For example, when are we trying to percuss it? I am trying to percuss this area and then go back on the parallel side, same way. I am trying to compare the sides anteriorly, infra-axillary, and then posteriorly, same way. Whenever we are trying to do posteriorly, we are trying to expose the interscapular space by asking the patient to keep the hands on the sideways. Again, I am not going into details. It is just giving a super view. Always, whenever I am trying to auscultate also, so I'll use my stethoscope, make sure I place it and try to compare the left side and the right side. Why? One thing which is very important, by inspecting and palpating, we are trying to locate which area is the pathological or disease side. Whichever is the disease side, we'll try to start with the opposite side. If we are thinking that the pathology is in the right side of the patient, so we'll start inspecting or palpating on the left side and then comparing it to the right side, which is very, very important. Okay. So this is there. So inspection, palpation, percussion, auscultation in all the four systems. So we have to do all the four systems simultaneously. After that, we come to a brief summary of the whole case. For example, a 54-year-old male patient presented with chest pain, which was 5 days duration, associated with mild in intensity, more left-sided, associated with cough, which was dry, followed by fever. On physical examination, patient has nil habits addiction, no significant history in the past. Then the patient presented to, so looks like, okay, simple lower respiratory tract infection by this. So because of all this, hemodynamically stable, only there was little tachycardia, there was increased respiratory rate by mild, blood pressure was normal, there was no clubbing, he does not, no lymphadenopathy, no cyanosis, no tremors, there was nothing. Then coming to the clinical examination, we thought respiratory clinical system is there. On respiratory examination, I found a small left-sided lower basal region, intercostal region. There was crepitation seen. No other positive finding on palpation or auscultation. So respiratory cardiovascular system was normal, neurological system was normal, and gastrointestinal system was normal. No obvious things, completely examined. There was absolutely nothing. So my interpretation is this looks like lower respiratory tract infection with probably community acquired pneumonia. With left-sided basal zone indicated. What are the investigations then we think of? Okay, fine. We'll do a complete blood picture, making sure we'll do ESR and CRP to make sure that what kind of pneumonia it is. If its CRP is high, ESR is high, or white cell counts are high. This is the thing which is there. Following that, I'll advise, yes, I would like to have an X-ray chest of this particular patient. X-ray chest, yes, X-ray showing a non-homogeneous opacity. So, see what happens in CBP? CBP hemoglobin would be normal, TLC would be high, say about 14,000. CRP would be 44. ESR is normal because it is not a long-standing disease. X-ray suggestive of left-sided lower basal non-homogeneous opacity. So this is confirming. This is why to confirm our case at the end of the day that it is these investigations, appropriate investigations to make sure which investigations are useful to us to come to a proper history and interpretation of this. So I think this is a basic review and overview of how to take history and how to examine all the systems and how to come to a proper conclusion by trying to, after your history and examination, you should know and try to delineate only one or two investigations should give us. But now, as we are in evidence-based medicine, beyond X-ray, we have got an HRCT chest done, which is to be there and which has to be considered because we have to make sure that everybody wants a proper diagnosis for a proper treatment. Hope this session was useful and I tried my level best to be as comfortable and more. If anything of any questions and all that, I think we have a session later on after the OBG session and then we'll come back for this. Thank you.
Jazakallah khair, sir, for your insightful and practical session. We truly appreciate the way you simplified history taking and examination for us. Your session has not only given us clinical clarity, but also motivated us to approach patients with more confidence and empathy. Jazakallah khair. Now, moving ahead, I take great pleasure in inviting our second distinguished speaker, Dr. Maleeha Fatima, MBBS DGO DNB in Obstetrics and Gynecology. Ma'am will be guiding us on history taking in OBGYN cases and examination of antenatal cases. Ma'am, we warmly welcome you to take over this. We'll be starting the session in 2 minutes. We appreciate your patience.
Assalāmu alaikum.
Walaikum assalam, ma'am.
Yes, Assalāmu alaikum everyone. So I'm here today. I'm Dr. Maleeha Fatima, obstetrician and gynecologist. So I'll be giving you a brief information on history taking and antenatal examination. So can I share my screen?
Yes, ma'am, you can.
Okay. Is it seen?
No, ma'am, it's not visible yet. It's visible now, ma'am.
Yeah. So, Bismillahirrahmanirrahim. So we are going to begin with history taking, followed by antenatal examination. History taking, briefly, I'll be discussing in both obstetric patient and then gynecologic patient. So to begin with, good history taking is the first step toward good patient care, and we need to ask the important questions to the patient because most of your diagnosis come from a proper history taking. If you are not able to take a proper history, then you might not get a proper diagnosis of the patient, especially in obstetric. So looking at what is antenatal care, what are the aims and objectives of antenatal care, why is it so important that we involve antenatal care? When a pregnant woman comes to a hospital, what instructions you will be giving to the patient, how frequently she should be consulting you, and what are the imminent signs that if she is at home, she is suffering from certain symptoms, what are the symptoms that she should be visiting to the hospital in emergency. So these are the basic things that I will be highlighting on. So what is antenatal care? Just a second. So systematic supervision, that is examination and the advice you give on each consultation to a woman during pregnancy is called as antenatal care. Certain definitions are also important in during your PG, like final year, and also during NEET examination. So this definition come from proper textbooks. So I have taken my proper all most of the definitions from Williams, and that are the basic book that you follow in your final year. So antenatal care is very important. It's a critical component for improving maternal and newborn health, and provides platform for health promotion, screening, and diagnosing the certain conditions and then preventing it in the pregnancy. And how you prepare a woman for a birth, explaining her what will be the process of her pregnancy, what are the process of labor, and making her mind fit for her to come when she comes in labor, and also preparation for the postnatal period and breastfeeding. So looking on to what are the aims and objectives to maintain the health of a woman throughout the pregnancy, that is important, and to screen the high risk cases to prevent pregnancy complications. So this is something very important. When you are screening any woman, like when any antenatal case comes to you, you might not know okay, what complication is she going to develop during her pregnancy, maybe during her labor, maybe post delivery. So you need to screen each and every woman for this high risk factors. So these are all in detail we will be discussing in later on classes. But to look on which women are going to develop preeclampsia, who are at a risk of developing GDM, you should be categorizing these patients, especially when the patients are obese and elderly. This things should be should be coming to our mind. If she is elder, then she is at a risk of developing preeclampsia. Usually, primigravidas are at a higher risk of developing preeclampsias. So screening this and preventing it is very important. And we also have to educate the mother about the physiology of pregnancy. Physiology of the pregnancy in a proper sense, like she'll be having nausea and vomiting because of the hormonal changes in the pregnancy that can happen. She can have acidity issue because the hormone progesterone, which is high in pregnancy, can cause delayed gastric emptying, and then there will be acid reflux and all. So this thing should not be getting the patients again and again to the hospital. If you give them if you educate them properly at their antenatal visits, constipations are can happen in pregnancies, acidities. These are all the common issues. So how to treat them at home, and nausea and vomiting, how it starts and then it subsides by 14 weeks. You should be able to counsel the patient properly. And to discuss with the couple about the place, time, and mode of delivery. This can happen like not in the first visit. You can like on her subsequent visit, you can talk to the patient, so that even if the patient comes in an emergency, so you can talk about the mode of delivery and the care of the newborn. And if you're especially looking, if you're anticipating that the patient is at the risk of delivering a preterm baby, in certain situation, like if she had a previous preterm delivery, or if she had a previous second trimester abortions, these patients are at a high risk of developing preterm. So these patients, you should be delivering in a setup where there is good NICU care with a good NICU or like pediatric setup. So these are all the important things. When the patient comes, you should be able to keep these all things in the mind, who are at a risk, who are able to like at a risk of developing preterm, and where multidisciplinary team is needed, and to motivate the couple about the need of family planning, and also appropriate advice to the couple seeking medical termination of pregnancy. So basically advice on family planning. See, women like who are not able to plan the pregnancy because of lack of family planning knowledge they have. So we need to advise them the proper placing of the birth, like if she is delivering and then again she become pregnant in 3 to 4 months, her she will develop problems, like she'll be having anemia, and then she won't be able to give proper care to the newborn, and then become very much occupied with the present pregnancy. So proper planning is very important. So, what are the important goals of antenatal care? Like, why are we so thinking about to give a good antenatal care? It's just that we need a healthy mother and a healthy baby at the end of the pregnancy. That's the whole thing I just want to convey from this thing. So, basically the goal is the safety and welfare of the mother and the fetus, and she should be prepared for the labor. See, many women who are young and who are experiencing birth for the first time may not have any knowledge about how the pregnancy goes, how the labor will be. So if you give a brief information, if you keep some charts in your OPD consultation room, how it's going to be, so it makes them prepare for the labor. So they'll be motivated for that. And also, every woman should be encouraged for lactation during pregnancy and also post delivery. So this, if you anticipate a high-risk pregnancy, as I already said, this can have a good reduction in the maternal and infant mortality and prematurity. Prematurity is one of the leading cause of perinatal mortality, and also it has a very depressive episodes on the mother. Because losing a baby after carrying for 7 months because of the prematurity is something we are looking seriously. So anticipation and recognition of the problems and intervention and treat or minimize the morbidity and patient education are the important factors of the antenatal care. Coming to very important things in the history taking. So whenever you take an obstetric history, to begin with, like when you complete what patient information, like considering her name, age, where she stays, these are all the important things that you need to note down. But age is a very important factor because see, again, the teenagers, early pregnancies at a higher risk of preterm deliveries, higher risk of developing preeclampsias. There is lack of knowledge. They are usually undernourished, undernutrition. So these girls are at a high risk of developing anemia during pregnancies. So age is a very important factor. So you need to give them proper counseling and explaining them what are the anticipated risk factors if you have a teenage pregnancy. What are the things that they need to look on. These are all the important things. Again, coming to the extremes, like elderly primary is like this has become a norm that most of the women these days are delaying their pregnancy just because of the career and all. So most of the women are like conceiving their first pregnancy in the 34, 35 years and maybe even late. By the time they reach 35 years and they start planning for pregnancies, and by the time they plan for pregnancy, it is like they get to know that they are infertile, they will work up, and then finally by the time they become pregnant, it will be 38, 39 years. We are also looking at primaries who are 42 years, 43 years also. So age is a very important factor. So again, this women who are above 35 years, elderly primary gravidas, are at a higher risk of developing preeclampsias, any complications during pregnancy, not only preeclampsias, diabetes during pregnancies, having preterm deliveries, having recurrent pregnancies loss because of the age and all. So as the age increases, the risk of abortion increases, the fertility decreases. So age is again an important factor. So when you're asking about the age, these all things should come to your mind and how you're going to counsel these patients. So gravida, like when a woman comes, she says you that I have missed my periods. So she has tested herself in the home, and then it has come to be urine pregnancy comes positive. So you will ask her, is this your first pregnancy? This is the first time that you have become pregnant. So the total number of times a woman conceives, irrespective of the outcome. Suppose she has conceived this time and then she aborted at about 7 to 8 weeks. Still, this gravida is counted. And suppose next time she becomes, next time she becomes pregnant, considering as previous abortion, we'll count it as a second gravida. So number of pregnancy, irrespective of the outcome, gravida has to be calculated. Coming to parity, the number of pregnancies reached till the period of viability, that is up to 24 weeks. So suppose a woman who has conceived previously and then aborted at about 7 to 8 weeks, you don't consider it as a parity, you consider it as a gravida. So she will be G2A1. And suppose if a woman have a live child and she is pregnant for the second time, then we write it as a second gravida, para1, living one. If the child, after crossing after a period of viability, if the child has died because of some reason, maybe during the labor, it was a stillbirth, or during after the birth, then we write it as gravida 2, para1, living living 0, dead 2, D2. So obstetric formula is very, very important. These are all the definitions of what is nulligravida, nulliparous, primigravida, primiparous. So nulligravida, suppose if your nulligravida is considered when you're taking a gynecological history. Suppose a woman who comes to you with maybe some complaint of infertility. Maybe she's trying to become pregnant, but she has never conceived, and she's looking for some workup on to become pregnant. Where is the problem that she's unable to conceive? So you write in the obstetric history, you will have to mention it as a nulligravida, which means this woman has never conceived, like she has never become pregnant. Nulliparous is a woman who has conceived. Maybe if she had a previous one abortion, so you can consider it as a nulliparous. Though she has conceived, but she has never crossed a period of viability. Suppose if she had 2 abortions, still she will be nulliparous because she had 2 abortions, which was in the first trimester, maybe around 7 weeks, 8 weeks, but she had never crossed a period of viability, that is 24 weeks. So primigravida is a woman who is pregnant for the first time. And primiparous is a woman who is pregnant and has crossed a period of viability. If suppose she is presenting to you at 30 weeks, 32 weeks, she is considered as primiparous. And then coming to multigravida, a woman who has been pregnant before, she may have aborted or delivered a viable child. So this is multigravida. So depending upon she has conceived before, and then she might have aborted or she might have a child. These are all the definitions that are considered in the gynecological history. And then grand multiparous is a woman who has completed 5 or more pregnancies. Parturient is a woman who is in labor. And puerpera is a woman who has just given birth. We consider it up to a period of 6 weeks postpartum. I hope this is clear to everyone. Is there any questions from everyone?
Yes, ma'am, it's clear.
Okay. So, see, a woman who comes to you for the first time, maybe I just said she has missed her periods, and then she's coming to you with a urine pregnancy test positive. So you see her in that first visit, you give her certain instructions, what has to be followed, and then the next thing should be, when are you planning to call her again? How frequently she should be visiting you? When do you ask her to come back? So these are all the important things. How the antenatal visits are again important. It is completely different in a woman who are at a low risk and then a higher risk woman. Women at a high risk, like who are at a risk of developing preeclampsia, GDM, maybe obesity, who has previous recurrent abortions, or a woman who is at a risk of fetal growth restriction. You call to see those patients more frequently than a low risk woman. So basically, the normal duration of the pregnancy, as we calculate from the last period of gestation, is corresponds to about 40 weeks, or it is 280 days. So as you all know from the textbook, that Needles rule is the formula from which we calculate the gestational age from her last menses. So last period date, first day of last period date is we have to add 9 months plus 7 days. That's all. Suppose the last menstrual period was on 1st January, you have to add 9 months plus 7 days to it to calculate her expected date of delivery, that we call is EDD. So in most of the pregnancies, maybe LMP might not correspond to last menstrual period. Last menstrual period might not correspond to the estimated date of delivery. This we get to know from our viability scan, where the radiologist to calculate the gestational age, and we call it as a scan EDD. So the scan EDD, if there is a variation of more than 1 week from the calculated EDD to the scan EDD, we consider the scan EDD as the date of delivery, not the one which we have calculated from the estimated from the LMP. So WHO antenatal care model, what they give the guideline for the antenatal schedule is, the first contact, they have to come within first 12 weeks of gestation, and then 20th week, 26th week, 30th week, 34th week, 36th week, 38th week, and then 40th week. So total 8 visits are recommended as per the WHO antenatal care model, at least, depending upon this weeks. So since in the first trimester there are less we don't routinely examine the patient, we don't look upon much things, so we just give the patient certain instruction of taking regular folic acid tablets, and if she has nausea and vomiting, so take those medicines. She gets a viability scan and come back with a viability scan around 12 weeks. So first 12 weeks are usually considered low risk if patient doesn't have any complications, like complications in the sense any previous histories of abortions or something like that. Again, by 12 weeks, if you see the patient for the first time, then you call her around 20th week. 20th week is again very important, because it is the time where we ask the patient to get their anomaly scan done, because TIFA scan is usually recommended 20 weeks, because most of the organogenesis gets completed by 20th week. So we get to know most development of all the organs by 20th week. And then just to follow up the growth of the baby, how is the baby growing, whether the liquor around the baby is fine, whether the weight of the baby is fine, we start looking at every 4 weeks difference as per the WHO guidelines. The guidelines as recommended by the American guidelines and the NICE guidelines are little different. So the old approach was different. Like we used to call more frequently in the late trimesters and all. This is the inverted pyramid, where if you are looking at a patient with who has a previous abortions or who has a previous genetic defects, chromosomal abnormalities in the baby, we call more frequently in the first trimester, followed by in the late trimesters. So what is the first visit or a booking visit? When the patient first comes to you with a complaint like of amenorrhea, that is, she missed her period and came with a UPT positive, maybe with a viability scan whatsoever, the first time she visits you is called as a first visit or a booking visit. So what are the important things that you do at a first visit or a booking visit is proper history taking from the patient, because history is very, very important. Like most of our treatment, diagnosis, whatever your plans are, it's all depend upon the history taking. If she gives proper history of her, suppose if the patient had a previous recurrent abortions, then you look the patient differently, because it's going to be a high risk pregnancy. If a patient has the previous history of any BP during her pregnancy, any sugar during the pregnancy. So everything has to be asked in this pregnancy. Even if she has delivered a live healthy baby, if she is already having a healthy live baby, what are the complications? Like, were there any complication during the process of the labor? Like, was she taking for any emergency cesarean section? How was the postnatal period? Was it all uneventful, or she had any peripheral sepsis, history of fever? All this has to be withdrawn from the patient. No one is going to tell you anything, but you need to ask these leading questions to the patient, at least where they reply yes or no. If they say yes, then what and how it was managed is an important thing. Then coming after proper history taking, you examine the patient, like general examination and local examination, and what are the investigations you advise to the patient. And it all depends upon each trimester. Like patient coming for the first visit, you may advise certain blood tests, antenatal profile, and then viability test. And then if she is coming for a subsequent test, we just don't need blood test every time. So then, what are the common ailments during a pregnancy? You should be explaining to the patient, like nausea and vomitings are bound to happen. There are risk of urinary tract infections during the pregnancy, so she need to keep herself hydrated, not holding her urine for a longer time. These are all the health education that a woman needs, and then you need to counsel every woman. And what are the importance of taking folic acid in a pregnancy? What are the importance of taking iron supplements and calcium supplementation to prevent anemia? Okay, these are all the things. Coming to history taking, like first you will be after the proper instruction, information of the patient. As I told you, you need to withdraw the obstetric formula of the patient, which is what is a gravida, what is a para, how many live kids, how many dead, were there any twins in the past. These are all the things, and after that comes the menstrual history. Menstrual history. Asking the menstrual history is very, very important, because whatever date you calculate the expected date of delivery, it all comes from menstrual history. If her cycles were regular, then as per the Eagles rule, you have to count 9 months plus 7 days to calculate her expected date of delivery. In case a woman says ki, no, her periods were irregular, then the last menstrual period might not correspond to the expected date of delivery. Then we might have to rely on the radiology, on her viability scan, to look for her scanned EDD, to look for like when is she going to deliver. And in case like duration of the flow is also important. How many days does she bleed? Menstrual history, like not only in obstetrics, it's also very important in gynecology. Just to know if any infertile people, if there is infertility, people are coming and they tell you that she doesn't have regular periods. If she has regular periods also, it doesn't bleed properly, then you should look at and things like the patient is suffering from hypothyroidism. There are certain conditions where the duration of the flow might be less, more, depending upon the condition. And then if she says ki periods are irregular, then you need to ask ki how irregular it is. Like, is it coming every 45 days? Is it coming every 60 days? Does it come in every 2 months or 3 months? A few women might be having so bad PCOS, polycystic ovarian syndrome, that they might not be getting a periods until and unless they take the withdrawal bleeding. So these are all the important things in menstrual history. So there is a lot to ask in menstrual history: whether cycles are regular, irregular, what is the duration of the flow, how much is the flow rate, how many pads is she changing every day. If she is complaining of heavy menstrual bleeding, then you might think of, if she is bleeding heavily and the cycles are regular, she is at a risk of developing anemia. She might have anemia. And you need to treat both the conditions simultaneously. Like, you should be looking at any hormonal imbalance, you have to correct it, and then simultaneously you have to treat her anemia also. Dysmenorrhea is like having severe cramps during, maybe which starts before her periods or during the period. That any pain that is affecting her quality of life in her day-to-day life, that she's not able to do her day-to-day work, then has to be considered. Dysmenorrhea might again be associated with the fibroids, uterus, maybe adenomyosis, the endometriosis. So these are all the things you might need to ask. If a patient complains, if you just ask the patient, ki, do you have any cramps during the periods? Then she will tell, yes, I have cramp. Most of the patient will tell, yes, I have very painful periods. So then you have to grade that dysmenorrhea. You will be asking the patient, you should ask the patient ki, how bad it is. Is it affecting your quality of life? Are you able to work on the first day of your period, or you just take rest? If she says, I just take rest, I'm not able to work, I'm just unable to get up from the bed, then that has to be considered. And it is like, are you taking any medicine for your dysmenorrhea? You people might need injections to suppress the pain associated with periods. So that is considered as a severe dysmenorrhea, where you are looking at something very important that needs cost treatment. Like if it is like dysmenorrhia, if it is basic spasmodic dysmenorrhia, no, I just feel little pain, I take meftal I'll be fine. No, I just use hot water bag, I am okay. So that dysmenorrhea need not need that level of consideration. But any dysmenorrhea is needing, patient needing 2 to 3 painkillers for the first 3 days of the period. Maybe if you are not even tolerating the oral medicine, that they will have to go to hospital and take injections. Such dysmenorias need to be corrected, and most of these dysmenorias are usually associated with some of the pathology, where this pathology can also be an important cause for infertility, irregular periods, and many things. Maybe hormonal imbalances also. So coming to last menstrual period, again, last menstrual period is important in obstetric history to calculate our estimated date of delivery. Coming to obstetric history, the first thing you should ask in obstetric history, you should be asking the patient like, how long is she married again? That is also important. If a woman conceives, maybe uh, within, if she says 7 months, I'm just 7 months married, I'm 10 months married, it clearly brings to our mind that, chalo, this is a spontaneous conception, that she has not taken any treatment and she has conceived herself. But a woman says, okay, I'm married for 5 years, 6 years, and then this is her first pregnancy. Then we might need to ask her, like, was there any problem in conceiving? Have you taken any treatment to plan your pregnancy? Did you conceive through IUI or IVF cycle? Because these are the precious pregnancies again. So they have taken certain treatment and they have become pregnant. So this is important for them. This is a precious pregnancy, and we might need to give little more importance to these pregnancies, because the women who have conceived through IVF, again IUI, are also at a risk of abortion, because the problem in conceiving may be because of the hormonal imbalance, some other pathology that was hitting their pregnancy. Coming to this, like we need to give this woman extra support, extra medicines, extra support in the sense giving progesterone injections. And in obstetric history, as I said, LMP and EDD, we calculate expected date of delivery. And also, if this is not a first pregnancy, if she has kids before, the history of previous pregnancy, how was it? Was it a normal vaginal delivery? Was it a cesarean section? If it was a cesarean section, why was the cesarean section done? What was the indication of cesarean section? And was it an elective cesarean section? It was planned, or like during the trial of labor, were you taken for emergency cesarean section? And what was the need for that emergency cesarean section? And any medical condition that she has suffered during a previous pregnancy, like any preeclampsia, PIH, maybe if not preeclampsia, also just PIH, that she was on any antihypertensive drugs, any anticoagulants, and any diabetes during pregnancy. These are, see, once they have a history of PIH, GDM, they are always at a risk of developing again in the present pregnancy. So any thyroid disorders they have in last pregnancy. How was the antenatal period, and how was the intranatal period, like postpartum recovery? How was the postpartum pregnancy? Was she able to breastfeed the baby? And any NICU admission to the baby. These are all the things you need to ask the patient. No one is going to say in your obstetric history, if you just ask, how was your last pregnancy? She will just take for normal delivery or cesarean section. If there was cesarean section, I don't know, doctor has taken for cesarean section, saying something, she will say. You have to ask the questions like, why did this not try normal delivery? Did they do any vaginal examination before and said there was they usually say कि रास्ता सही नहीं था बोले doctor. You should anticipate कि it is a CPD. And so basically next pregnancies also she will be going for cesarean section. And any GDM during pregnancy, was she on insulin, was the baby overweight, any complication, so weight of the baby, how was the baby delivered, any NICU admission. These are all the things you need to ask from the mother. And coming to present pregnancy, again, you should ask whether it is a spontaneous conception, whether she has conceived spontaneously or has she taken any treatment to plan her pregnancy, IUI, IVF, whatever it so may be. So what about the immunization? If the patient is coming to you for the first time, around, suppose if she comes to you at around 28 weeks for the first time, taking her previous antenatal visit at some other place, and she doesn't have any documentation of what she has taken, what medicines the previous doctor has given. So you should be asking her, did they give any TT injections? Were you taking folic acid supplementation? Did they give any iron tablets to you? This question should be asked. And coming to medical history, again, history of like what has happened in the previous pregnancy might not be continued. Suppose if you had developed GTM in the previous pregnancy, usually by the end of the pregnancy, maybe after 6 weeks, if she has done her glucose tolerance test, GTD, it has come to be normal. So she stopped taking her oral diabetes medicines and all. So maybe few women who have developed PIS during a previous pregnancy may continue to have a hypertension, and then this pregnancy also she will become a case of gestational hypertension again. So any medical disorders present like hypertension, diabetes mellitus, thyroid, asthma, epilepsy, even if a primary is a primary who is coming to you, you should ask for all the question whether she is already taking any antihypertensive drugs. Because if she is already taking any antihypertensive drugs, we need to we need to consider whether this drugs, whatever she is taking now, is safe to continue in pregnancy. Few women might be continue maybe on tablet telmisartan or some other tablets, but this telmisartan is not safe to continue in pregnancy. So we need to advise her to stop this medication and give her the medicine that is safe to take during pregnancy. So proper history about her medical history, like hypertension, what are the medications she is taking, how many times in a day she takes, and since how long she is hypertensive, and diabetes, how frequently she monitor her sugars, thyroid, how long it's been like she's taking her thyroid drugs, were there any abortions, because hypothyroidism are usually associated with pregnancy losses and abortions, and also infertility, any asthma or epilepsy, because she might need treatment during the pregnancy also. So getting to know any disease she is suffering from, we might need to give a consideration what are the drugs we can plan her in this pregnancy. If she is already taking the drugs, we ask her to stop those medicine and give her the drugs that are safer in pregnancies. And surgical history, suppose if she has any past histories, past surgeries, you should ask about it. Because if you are going for a repeat cesarean section and all, cesarean section, if she has any past surgeries, you can anticipate the woman may have adhesions from the previous surgeries. So you will be prepared for any complications to manage. Family history, again, history of any congenital anomalies, any in the like first degree relative, especially when the marriage or consanguineous marriage, you need to ask any congenital abnormalities in the family, history of any Down syndromes in the family, or any other relevant history if they can give. Drug history, again, was she allergic to any allergic to any medicines in the past, has to be asked, because you avoid giving those medicines again in this pregnancy. So risk categories, as I said, you will have to categorize the woman. So, and also depending upon this risk category, you will decide how frequently to call her to monitor this pregnancy. So low risk mother with a low risk fetus is just an expectant healthy pregnancy outcome. So basically, we expect a healthy pregnancy outcome. The mother and baby are going to be healthy. So if this is something where the woman is young and she has conceived spontaneously, she doesn't have any comorbidities, there is no thyroid, no hypertension, no gestational diabetes mellitus, she doesn't have anemia, she has taken her folic acid supplementation properly, she is taking properly her iron and calcium supplementation, she is very compliant patient, she comes properly on antenatal visits to consult the doctor, she gets her scans regularly. So these are the women who comes under low category, where the both mother and fetus are going good on every antenatal visit. So low risk mother with high risk fetus are the healthy pregnancies. Mothers are usually healthy, but unexpectedly where we anticipate that fetus might get compromised. Suppose RH isoimmunization, maybe a woman have previously delivered a baby where she was RH negative and the baby was RH positive, and she has not taken in any anti-D injection. then the second baby is very likely to be affected, and or any congenital abnormality in the baby where you think the baby is any heart disease in the baby that is correctable after the delivery. These are the fetuses at risk. Again, high risk mother with a low risk fetus. Suppose fetus is fine, all the scans, baby growth is going fine. What are the factors we look at, like parameters like abdominal circumference, weight, everything? Baby growth is going as per the expectation, but the mother is suffering from certain diseases like thyroid, maybe asthma, where we see, or is she on any blood thinners for her condition? This mother with a cardiac disease, these are all the mother at a high risk, but the fetus is going good. So high risk mother with a high risk infant. Again, suppose if any condition of the mother, suppose if the mother is suffering from severe hypertension, severe preeclampsia, any liver diseases, or any other condition that is affecting both the mother and the child. Suppose if the mother has a hypertension, then it will definitely affect the placenta and the blood flow to the baby. So baby is not growing as per the expectation. The fluid around the baby becomes less, oligohydramnios. So these are all the things where the high risk mother and high risk infant, we need to carefully monitor this pregnancy. We should be calling these patients every 2 week for checkup. And late in the pregnancy, we might need to consider frequent non-stress test, NST test, and the scans depending upon when to plan the pregnancy. They might even need a preterm delivery for a better outcome of the pregnancy, where we plan to give a healthy baby to a healthy mother. Coming to examination, these are all the important points that I think I could cover in a history taking. Like if anyone has any questions in history taking, they can like raise their hands or ask me whatever is needed so that we can proceed with examination. So should I go ahead with examination?
Yes, ma'am, you can proceed. We'll take up any questions later after the session.
Sure, sure. So coming to examination again. So it all starts with monitoring of our vitals. You check for the patient's blood pressure, pulse, respiratory rate, temperature, and SpO2. Temperature, again, if a pregnant patient comes febrile, what are the conditions you are looking at? Urinary tracts are very common in pregnancies. So you can like categorize the thing. If patient doesn't have any symptoms, just fever, what are the things that you are looking at? If she have upper respiratory tract infection, how do you treat it? How do you advise her during the pregnancy? And then coming to general examination, you monitor her height, weight. Again, height and weight are important. You calculate BMI. Depending upon the height of the patient, you have to anticipate whether this woman is going to deliver normally or she is going for cesarean section, like severely. If the woman is usually short stature, then they are usually associated with the cephalopelvic disproportion, and this woman cannot deliver normally. They might need cesarean section for their delivery. And then coming to weight again is important because normal weight with a normal BMI might not have any complications, but again, underweight, teenager pregnancy where the weight is very less, are at a higher risk of having abortions, are at a higher risk of having preterm deliveries, are at a higher risk of having IUGR babies, like fetal growth restrictions. And again, if the woman is obese, they are again at a risk of having abortions. Then other complications like developing diabetes during pregnancy, preeclampsia during pregnancies. So weight is again an important factor. Depending upon the weight, and like you will also have to counsel the patient ki your weight is if it's coming in the normal BMI, how much weight gain during the pregnancy is recommended. If her BMI is normally expected weight gain by the end of the delivery is about approximately 10 to 12 kgs. If the patient is already overweight, you counsel her, you tell her not to gain excess weight during the pregnancy in order to prevent complications. So you will tell her if the expected weight is 10 to 12 kgs, she have to gain only 8 to 9 kgs of weight during the throughout her entire pregnancy. If the patient is usually obese, if she's already obese, then you will have to tell her to have a very controlled weight gain during pregnancy, maybe less than 7 to 6 kgs, not more than that, in order to avoid complications. Because again, there will be a risk of developing deep vein thrombosis. If they gain excess weight, they won't be able to walk properly after the delivery. So weight is important in all these factors. So you'll be looking at CPD. If she's underweight, you're looking at risk of preterm abortions, obese patients are again, how you advise them to gain weight during pregnancy is important. And pallor, icterus, clubbing, cyanosis, these are all the part of all the history taking, not just gynecology. In any part of any subject, like maybe general medicine, surgery, these are all the basic things we look at: pallor, icterus, clubbing, cyanosis, lymphadenopathy, edema, and varicosities. And I think Ahrar sir has covered already on taking pallor, icterus, clubbing, cyanosis. So coming to pallor, of all these things, pallor and icterus is very, very important in pregnant patient, because pallor is something you are looking at a patient to diagnose anemia. Maybe you see a patient who are coming to primary health centers, who are not regular for their antenatal visits. They come just in every 4 months, 3 months. So pallor is like, you don't have a advantage of doing CBP so easily, where you can see the blood test. So if you just looking at the patient pallor, you can anticipate that she is anemic, and then you can advise her to go take CBP, and depending upon the CBP report, you can advise her whether to take oral iron, whether her hemoglobin is so less and the pregnancy is advancing, whether oral iron won't be able to compensate the blood loss that she is going to face during the pregnancy. So you advise her to take injectable irons, or she might need blood transfusions. So this is how the pallor is important. Again, icterus is not a good sign during the pregnancy. Any altered liver function test may be associated with severe preeclampsia, PIH, or other liver diseases during pregnancy that need to be looked on. Again, clubbing, cyanosis, lymphadenopathy, edema, varicosities, depending upon the cause. Physiological edema during the pregnancy is very much common to have, especially the pedal edema. You should be looking at the grade. But any sudden development of edema that is increasing the patient weight has to be looked on, because it maybe the PIH or the underlying preeclampsia may get deteriorated, that might lead to sudden development of edema. The edema may just not be the pedal edema. It might involve all her body, hands, abdominal wall. So if there is edema, the grading of edema is important, and it's just pedal edema. Pedal edema or the physiological edema of the pregnancy usually subsides after the rest. So if any woman complaining, I am getting a peak swelling, pedal edema, you should be counseling her the physiological edema. This is the physiological edema of pregnancy. You need not worry. If that edema subsides during the after the rest, then uh, she should not be concerned about it. Coming to examination, obstetric examination, like after the general examination, you come for a local examination where we'll be seeing the abdominal examination. So first we have to take a verbal consent from the patient that you are going to examine her, and then you're going to expose her. So verbal consent for the examination is important. The patient is asked to empty her bladder so that she doesn't face any difficulty during the examination. It doesn't cause her any discomfort. And the abdomen is to be fully exposed. You should be able to expose the abdomen properly, so that you can see any you are able to inspect properly. You are going to palpate properly, so it has to be fully exposed. The examiner should be standing on the right side of the patient. The examiner should always stand on the right side of the patient. That is the any examination requirement. So first we do an inspection. So we look at the uterus, whether the uterus is ovoid or longitudinal, transverse or oblique. So depending upon the shape of the uterus, only you can you can just make a decision. Oh, this looks like an longitudinal line. This looks like a transverse line. So shape of the uterus is important, but shape of the uterus, like, more importantly, corresponds in the later gestation. Initially, you might not be able to make much from the shape of the uterus. Maybe by 24, 28 weeks, it doesn't give you much information. But 30 to 34 weeks, when the uterus is completely occupying the abdomen, if it is longitudinal, you can then make out whether it's a longitudinal line. Coming to pigmentary changes in the skin, we all know that there is a pigmentary midline line that is called as the linea nigra. That is because of the melatonin deposition of the increased melatonin deposition of the skin. Then stria gravidarum are the stretch marks. As the abdomen grow, like as the uterus grows, so the abdomen also grows. The skin over the abdomen gets stretched, and that causes the certain stretch mark. The stretch marks are nothing but the stria gravidarum during the pregnancy. Coming to the skin condition of the abdomen, any ringworm infection or any other infection, you have to look on inspection and then treat accordingly. Any previous incisional scars, if she is a case of previous cesarean section, you should be looking at whether it was a lower segment cesarean section, whether the vertical incision was taken, or any history of any previous surgeries, like history of appendicectomy, any scars looking at. You should be asking the patient the surgical history if you look at any scar. And then coming to after inspection, we proceed with palpation. So the first thing we look at palpation is the uterus is to be centralized. Most of the, as we know, the uterus is because of the sigmoid colon on the left side. If it is loaded, the uterus is dextro-rotated. So the uterus is to be centralized if it is deviated, and then you should proceed with your examination. The alar border of the left hand is placed on the fundus and fundus, and then it is gradually brought down till you feel the resistant point. So depending upon at what level you are feeling the resistant, it corresponds to that period of gestation. So we consider at the level of umbilicus to around 24 weeks. 2 fingers above it, you increase by 2 weeks. So coming from the fundus, you should be coming down. If it is at the, you feel it at the Ziphius sternum, it is approximately at the 36 weeks of gestation. Like if it is like before 2 fingers below the Ziphius sternum, we can tell it as a 34 weeks, and at the level of Ziphius sternum, it's a 36 weeks. But it is at the 2 fingers below the Ziphius sternum, but you feel the flanks are full, then it has cross the period term period. It must be somewhere around 38-39 weeks. Then or you can also calculate using the tape the symphysofungal height. How it corresponds, the centimeters correspond to the period of gestation. If it is 36 centimeters, then it is a 36 weeks of gestation. Okay. So when you are looking at the symphysofungal height or the fundus examination, whenever you're doing, so at times there may not be, like the fundal height might not be corresponding to the period of gestation. Suppose if you're calculating her EGD from or a period of gestation from a last menstrual period, it might be corresponding to around 28 weeks. But when you examine the uterus, might look a little higher or a little lower. Maybe it might look only 24 weeks, or it might correspond to 30 weeks. So there are certain conditions where the height of the uterus does not correspond with the period of gestation. So if it is not corresponding, what are you looking at? It should come to your mind. If you are looking at 28 weeks of pregnancy, if you're like your period of gestation, what you have calculated from your scan EDD or from your last period of gestation is corresponding to 28 weeks. But when you're examining the patient, but it actually shows the pregnancy is around only 24 weeks. So there is a discrepancy of about 4 weeks. What could be the problem? Are we looking at an intrauterine growth retardation? So you carefully need to see these patients when there is a discrepancy. So when the height of the uterus is more than the period of gestation, you might look at like patient must have given you a wrong date. They might not be sure about the last menstrual period, or if she has done a viability scan. If she has done a viability scan, then according to a viability scan, we should calculate her gestational age from her scan EDD. Or multi-gestation. If suppose she's carrying a twins, you might not know. A woman for the first time coming to you at around 24 weeks. 24 weeks, she might be coming to you for the first time, and then she just says she's pregnant. She has not done any scans till now. So if you're performing an antenatal, she just tell you her last period was so and so. Before that, her periods were always regular and on date. So you think that periods were always regular. This is the last menstrual period. So you are basically calculating her estimated date of delivery and gestational age from a last period date. So if it is coming to around 24 weeks, and then you are looking at a uterus which is showing it is approximately around 28 weeks, and you feel multiple parts, then there is a multiple gestation you are looking at. And even if there is a singleton pregnancy, but the Likert around the baby is higher, there are certain conditions where the Likert around the baby can be higher. We call it as polyhydramnios. If the water is excess, then the uterus must be corresponding to higher than the period of gestation what we are calculating. Then again a big baby. Uh, Suppose mother is suffering from the gestational diabetes mellitus. She's at a risk of developing big babies because of her diabetes. So this women are like baby can be bigger than the period of gestation. Any pelvic tumors, ovarian tumors, or fibroids of the uterus can make the uterus look bigger than the period of gestation. And again, herediform mole, because of all the vesicular granules and all, there will be excess hypertrophy of the uterus because of the excess beta HCG. So the period of gestation may look more than the period of the height of the uterus might look more than the period of gestation. or any hemorrhage. This is very important. A woman during pregnancy, maybe in her later pregnancy, at around 34, 36 weeks, she comes to you with a over-distended uterus. It was a single-gen pregnancy that has been confirmed from the previous pregnancy, and she tells you there is a lot of pain. It might just be not labor if the uterus is over-distended. Sometimes there might be hemorrhage inside, and it is concealed. Nothing is being revealed. Such woman has to be considered if the uh, uterus looks over distended. So full bladder is doesn't make much difference, but okay. But in the early pregnancy, maybe when you're looking at around 12 weeks, 14 weeks, because the uterus becomes is a pelvic organ, but 12 weeks gestation. We will be able to palpate the uterus only after 12 to 14 weeks of pregnancy. So once we start palpating the uterus early in the pregnancy, if the bladder is full, there might be little. If you're looking at a 14 weeks pregnancy, might look 16 weeks, 17 weeks. So full bladder is important in the early pregnancy, but not in a later pregnancy. It doesn't make much difference. So coming to the height of the uterus is less than the period of gestation. Again, I said you might be looking at again wrong dates, or the Lycaon on the baby is diminishing, or it is very less, or there is a fetal growth retardation, or also when there is intrauterine death. Maybe there was intrauterine death around 24, 28 weeks only, but the mother did not come to hospital at around 32 weeks also. So the death has happened almost 4 weeks back, 3 weeks back. This baby's might abdominal uterus height of the uterus might look smaller than the period of gestation. So there is a lot you can get to know from the height of the uterus. This is a very important part of your examination, especially palpation. The first step, the height of the uterus. When you look, you should be able to first thing you need to address is whether the period of gestation is corresponding to the height of the uterus. That is what is more important. So if it is corresponding, suppose if she's 24 weeks and the uterus is corresponding to around 24, 25 weeks, there is really nothing to be worried about. But what are the factors where the height of the uterus can be more or less? These are the first thing that, see, before even you look at the heartbeat, you can anticipate many things. If the height of the uterus is not corresponding to the period of gestation, there should be a number of things that should be coming to your mind. If height of the uterus is higher, so am I looking at a polyhydramnios? Am I looking at a multiple gestation? Is it any hemorrhage inside? Or is she having? Did she tell you the wrong dates? Then you will have to follow up with her scan reports, or looking at the fetal heart rate. Coming to grips, so the important part of the examination, we have been doing from the beginning, is the Leopold maneuvers to come to a conclusion. How is the lie? What is the presentation? Whether the head has engaged or not? Where is the back? Where is the limbs? So this examination give us the information as on how what is the presenting part, whether it is a head or a breech presentation, whether it is a longitudinal lie, transverse lie, or a oblique lie. So Leopold maneuvers, there are 4 steps. There are 4 grips basically. We call as first one is the fundal grip. Second one is the lateral or the umbilical grip. Third is the pollex grip. Fourth is the pelvic grip. So patient should be counseled again that if you are going to examine her, consent should be obtained. Make sure the bladder is empty, and then palpation should be conducted with utmost gentleness. And this maneuvers are usually performed later in the pregnancy. See, the fundal grip which you are seeing to find the period of gestation is usually done at each visit she comes to you. At maybe around 20 weeks, you still look at the uterus to see whether the period of gestation is corresponding to the height of the uterus or not. But these grips are usually done later in the pregnancy to prepare her for labor. Whether there is a longitudinal lie, how's the presentation, whether the head is engaged, so that you can plan her pregnancy. So coming to the first grip, so first 3 grips, the fundal grip and the lateral grip and the pollex grip, are usually done. It is done facing the patient's face. The last grip, the fourth grip is done facing the patient's feet. So this is important. Uterine fundus is palpated first. In the first grip, we palpate the uterine fundus as shown in the image. With both the hands, we keep over the fundus to find out what is the whether it is head, what is the presentation, whether it is a head or breech. If you feel a smooth, hard, and globular mass it is usually suggestive of head. See, if you're missing a breech presentation, like on the frontal grip, you're missing, if you're unable to palpate the legs or buttocks properly, that is okay. But head is something that should never be missed, even on the first grip or the third grip. Head should never be missed because you'll be able to feel like a proper smooth, hard, and globular mass. It will be floating if you move it from side to side. So if it is smooth, hard, globular mass, it is definitely suggestive of the hand. But if it is broad, soft, and irregular mass, it is suggestive of breech. At times, you can feel the buttocks. Whether in a transverse line, neither you feel the fetal pulse nor you feel emptiness in the fundal area. So it will be just like a slipping over your hands. So in the transverse line, you don't feel fetal pulse, neither the head nor the breech. Coming to lateral or umbilical grip, that is a second Leopold grip. So, as I said, after correcting the dextrotation, the hands are to be placed flat on the either side of the umbilicus to find out the position of the back, limbs, and the anterior shoulder. The back is felt. If you feel a back, it will be like a continuous, smooth curve and resistant feel you have. Whereas the limbs will be felt like small knob, irregular parts with gaps in between. Back will be felt in continuity. The position of the anterior shoulder is to be checked. It forms a well-marked prominence at the lower part of the uterus. Anterior shoulder can be felt properly. Coming to Pollick's grip, this is a third grip. The thumb and the forefingers of the right hand are stretched and placed over the lower pole of the uterus. In the lower pole of the uterus, you stretch your right hand with the thumb on one side and your forefingers on the other side, and you try to move your fingers and thumb from side to side. If it gets approximated, the presenting part is grabs. When the fingers and the thumbs are approximated, the presenting part is grasped. So it means that it is not engaged. But if you are able to move the head from side to side with properly grasping the head, then it means it has engaged. In the transverse lie, again, the Pollick's grip is empty. You won't be able to feel on either the head nor the breech, limbs or foots, anything. It will be empty. Coming to the pelvic grip, as I said, this grip is the only grip where you will be facing the patient's feet. The four fingers of both the hands are placed. You face towards patient feet. Both the hands you keep on the either side of the midline in the lower pole of the uterus. This is again to confirm whether the head has engaged or not. The fingers are passed down, pressed downwards. Okay. So press pass downwards to palpate whether the head has engaged or not. If it is a head, the characteristics note are presenting part, attitude, and engagement. You will get to know if it is a head, the presenting part is cephalic presentation. The attitude is like whether the head is flexed or not, and whether it has engaged or not. If your fingers are, yeah, I'll show you. See, abdominal palpation to determine the engagement of the head. Divergence of the fingers. If it is divergent, fingers are diverged, then the head has engaged. So that's the reason your fingers are not meeting down. And the convergence is the head is not engaged. Coming to the last part of our palpation, that you end up with this auscultation, where you look at the heartbeat of the fetus. Usually the heartbeat is felt if you draw an imaginary line from the anterior superior iliac spine to the umbilicus. Along the anterior superior iliac spine to umbilicus, whatever the imaginary line, midway between that, you will feel the heartbeat, baby's heartbeat. Fetal heartbeat is heard around the umbilicus in the cephalic presentation, but it might differ in a breech presentation. You will be feeling the fetal heartbeat in the upper abdomen, and it also differs in the occipital lateral position. Fetal heart rate is heard toward the mother's flank on the same side if the baby's presentation is occipital position, lateral position. So there are two shuffles that you can misheard as a fetal heart sound. So phonic shuffle, these are not the fetal heart sound, but the phonic shuffle might resemble the fetal heart sound, but it is a sharp whistling sound that is synchronous with the fetal pulse, but those are the pulsations of the umbilical arteries. Similarly, the pulsation of the uterine arteries, if you it is heard as a soft blowing sound, it is synchronous with the maternal pulse. So with this, I have completed my palpation. So history taking and examination manuals I have completed. So the next class, if you are looking, we might look at tests and investigations in the first visit and the subsequent visit. So thank you so much for all your time. Thank you so much. I end my session here. Any questions from anyone? I appreciate it.
Thank you so much, ma'am, for such a comprehensive and enlightening talk. Your session has truly added depth to our understanding of clinical practice in obstetrics and gynecology. Jazakallah khair, ma'am.
Vayyakum. Thank you so much.
Before we conclude, we'd like to take up a few minutes for a short Q&A session. We'll keep this session limited to around 10 minutes, so let's make the most of it. All the participants, you can unmute yourselves and ask your questions to the speakers.
So Faria has a question here, like between the scan EDD and the calculated EDD with LMP, what we have to prefer. So basically, see, first, we always consider calculating the estimated date of delivery always from the last menstrual period, provided there are criteria, like her period should be regular and regular, and she was not on any contraceptive pills to regularize her periods in the last 3 months. So you should be asking this. If her periods were always regular, so you calculate her estimated date of delivery from her last menstrual period. That is going to be 9 months plus 7 days, whatever from her last menstrual period. So as I said, if her last menstrual period was on 1st of January, so you calculate it as if again February, March, April, May, June, July, 9 months plus 7 days. So it will come somewhere around 8th of October. Provided, see, you have calculated her estimated date of delivery, but you do a viability scan where you get to know her scan EDD is showing that her scan EDD is somewhere around 28th of October, not the 8th October. So you will definitely have to consider her scan EDD to plan a pregnancy or delivery, and at each visit, her gestational age should be calculated from her scan EDD only, not from her LMP. So whenever there is a discrepancy of more than 1 week between the calculated EDD and scan EDD, we always consider scan EDD, not the calculated EDD. I hope I am clear. Patient is obese, you mean to say? Okay, I have another question from Paria, I think. Patient and have a history of diabetes mellitus in her pre-pregnancy and means planning for next pregnancy. If she lose her weight, does the changes of having DM again in the next pregnancy or not? See, once a risk of gestational diabetes mellitus in a pregnancy, even if it is lean, forget whether she's obese or not. Even if she is lean or normal weight, a normal BMI patient, if she has developed gestational diabetes mellitus in her pregnancy, there is always a 50% risk of developing diabetes later in her pregnancy. May not be gestational diabetes again in her pregnancy, but there is always 50% risk of developing diabetes again in her pregnancy. So not only obesity, there might be family history of having diabetes mellitus. There might be genetic factors that was the reason of her diabetes mellitus, not just obesity. So definitely the risk of having diabetes in subsequently pregnancy is always increased. Any more from anyone?
Yes, ma'am, I have a question.
Yeah,
How
please.
do we sensitively approach an obstetric patient who may feel shy or hesitant, or how do we approach the history of previous abortions in a patient because they're reluctant to share that information, or it might
Yes.
emotionally affect them?
Exactly. So, see, the first thing, especially usually if the women are presenting in late 25, 26 years of age, they are usually not that hesitant for any examination or something if you properly explain them. So, teenager girls or maybe 20, 21 years, these are the girls who are very shy to give any history or for examination also. So, you should be telling her, if you give me a chance to examine you, then I'll be able to anticipate anything, like maybe your growth, how is the growth going. You tell her the importance, what are the importance of examination. See, one thing is, I can tell you, once you hear a heartbeat, and if a mother is able to hear the heartbeat of the baby, that gives them very confidence for her any next examination. So you should be making her listen to her baby's heart sound, maybe with a fetal Doppler or something like that. These are the positive signs. So any mother will be very happy to hear to a fetal heart sound. And also you should tell her the importance. You should be telling her the importance. See, if I examine you, I will be able to know whether the pregnancy is growing at a normal basis. Is there any baby is not growing properly? These are the important things that I'll be knowing from this examination. So please let me allow this. And if she is hesitant, like if there are more number of people around, like maybe if there are interns, if she is not feeling comfortable, you should be asking her. You want some of the doctors to leave the room, and then you should go ahead with the further examination if she is not filling with so much people. Another thing you asked was history of previous abortions. You should tell them, was there any history of? See, in this era, I can tell you most of the women, most of the girls, I can tell you, are becoming pregnant even before they get married and they are undergoing abortions and all. I'm pretty sure no one will be revealing about their abortions before marriages that have undergone. In case if they are become like they are marrying to another partner, so they won't reveal this history. So. Most of the abortion history we usually cannot take out, but in case like not if they it is not disturbing them, you can ask them ki, see if there was any history of previous abortion, I'll be able to manage previous abortion in the sense like was their pregnancy growing in properly in the first half of the pregnancy. Maybe there was abortion around 9 weeks, maybe around 10 weeks. So what was the cause of that abortion? We can find out, and then we can give a like importance in this pregnancy, and we will be able to treat the cause. We can prevent it in this pregnancy. You should be able to educate her. So just asking her kuch abortion hua hai kya pehle time, it doesn't give them anything. So if there was any history of abortion in the past pregnancy, we will be able to manage and prevent it further in this pregnancy. If you can give that history, you should be asking the question in that sense. So they will definitely reveal you if there was any.
Okay, ma'am. Thank you so much.
You're welcome. And someone asked, would there be any reaction if the baby is dead for more than 4 weeks and it is discovered in the next antenatal visit? See, usually in the early pregnancy, I can tell you where the pregnancy is maybe below 20 weeks and all, people do come after 4 weeks, 3 weeks of intrauterine demise also. But later in pregnancy, people are usually conscious. So once they start feeling the antenatal fetal movements, if they don't feel the movement for 3 days, 4 days, so the chances of woman coming to the hospital is early, because she comes with a complaint that she is unable to feel the fetal movements for the last 3 days, 4 days. So missing an intrauterine death for 4 weeks in a later pregnancy is less. But yes, there are always a risk factor for if the intrauterine death is more than 4 weeks, if the woman is not coming, there is going to be reaction. It will lead to intrauterine infection, and then the risk of developing discriminated intravascular coagulation. These are all the important things. So early in the pregnancy, it can be missed for 3 to 4 weeks, but later in the pregnancy, the chances are less until the woman is very negligent. Once IVF is done for the first pregnancy, meanwhile for the other, we need undergo. No, there are many patients who undergo IVF for their first pregnancy and they come with a spontaneous conception later in the pregnancy, depending upon the cause of the pregnancy. Certain conditions might need repeated IVF, but not all conditions.
I think that's it for the questions. We'll conclude the Q&A session now.
Sure.
So on behalf of IMSA, I extend heartfelt gratitude to both of our esteemed speakers for taking out time to guide us, and to all the participants for their attentive presence. Jazakumullah khair. With that, we come to the end of the session. I request all the participants to fill up the feedback form, which will be shared, and this will help us enhance your experience in the next sessions, inshallah. May Allah subhanahu wa ta'ala grant us beneficial knowledge, allow us to apply it in the service to humanity, and accept our efforts. Ameen. See you in the next sessions. Jazakumullah khair.
Thank you, everyone. Thank you so much. Allah Hafiz.
Thank you, ma'am. Jazakallah khair. Assalamu alaikum wa rahmatullahi wa barakatuh.